Thank you. All right, so everybody out here, thank you for coming to our program in Nashville. So my name, for those that don't know, there you are, Stuart Schlossman. I have to look down and remember who I am from time to time. Tonight's program is sponsored by Genentech and Alexion. And then for the exhibitors, we had Novartis and Banner Life Sciences, Bristol Myers, and Alexion again. All right, let's give them a round of applause. Thank them for being here. Thank them for supporting this program. All right, tonight we have new topics, one slightly different than others. So Dr. Hunter is here. Dr. Hunter, that big guy over there. All right, so Dr. Hunter is here. He'll be speaking about the basics of learning about the MS diagnosis and other autoimmune diseases. He'll do a little bit on symptom management, and it's all about Dr. Hunter tonight. Let's welcome Dr. Hunter.
I appreciate the opportunity and the invitation, and especially doing something in the Nashville area. We're gonna expand and talk about other diseases that we have to distinguish for MS early on, and people with MS often have many other diseases, both common and uncommon. But there are diseases that we used to think were multiple sclerosis, but we call them by different names now. And they're still very much like multiple sclerosis. They're cared by the same people. We're going to go into those just a little bit today, but they are rare diseases compared to MS. MS is a really common disease. We have had success with multiple sclerosis, the kind of success that comes from really good science and really good industry have produced a host of therapies for MS. And better treatments as years have gone by. But some of the older treatments, and even some of the more effective and advanced treatments, have gone generic. And that has created a situation that's very novel for people with MS, where you don't have support always from manufacturers for these older products, and they're not always as cheap as you would like them to be. So when a drug like Tecfidera, which is a big brand name drug, goes generic and gets called something else and has no manufacturer assistance, and you look at one pharmacy and it's $40 and another pharmacy and it's $4,000 a month, you go, what's going on? And you're not the only one, and you start looking at other jobs, and there are 3 different medicines in that family. They're all good medicines, and some of them are better, than dimethylfumarate. But, it's the kind of thing where if it isn't broke, you don't fix it in medicine. And if it works fine for you, everybody's happy. There are a number of S1P medicines, and the first one is gone generic. Wasn't a particularly easy drug to use, but it's still out there. And there are other ones that are out there. And Aubagio, which we used to call a fairly current medicine, is gone generic. And you're going to see the same thing happen. And these are drugs which took a lot of money to develop, and we're in a very competitive, high-price market with MS, and are not anymore. They're out there, and they're available, and you might use them sometimes. So it's good to know that. There are other drugs that don't become generic, and these are biological drugs. Biological drugs are not generic because they are not chemical entities. They are made by very specialized processes, which are neither cheap nor easy to do. And so essentially, it's like getting a drug approved twice to get a biological drug. They have to approve the factory, then they have to approve the drug. And so there's a new drug that came out that's a lot like Ocrevus that's out there. You may have heard all the commercials for Symptom on TV, which is kind of a lower dose of one of these drugs. And there's going to be a drug that's just like Tysabri that's coming, and they're called biosimilars because they are the same drug, but they are not made like chemicals. So, and there are things that are out there and not available yet, but they're coming, and they'll be here someday. There are drugs that are coming down the road, many years down the road. There really is nothing earth-shatteringly different than we already have. It's all variations on the theme. And highly engineered, very bold new ideas for how to approach MS, how to try to improve MS. And companies have spent a lot of money testing new things to try to find game changers in MS. And we'll see once they have data. You never know. But really, strange and new ideas are being looked at out there, because something's got to be really good to be better than the stuff that we already have. So Stuart asked me to talk about different immune diseases. And different immune diseases are diseases that have some similarities to MS, but are different from MS. So in order to talk about different diseases, we have to talk about what MS is and how we diagnose it. And believe it or not, that journey began just 150 years ago when there was a revelation by some French doctors who worked in, I kid you not, they ran the insane asylum. They ran the insane asylum in Paris. That was their job. And it was their job to take care of those people and try to treat them in the period of the Enlightenment, when there was all this education and development in science. And they realized not all these people were crazy. But if you shook or you lurched, somebody thought you were crazy and they threw you in an insane asylum. And so the neurologists had a chance to examine these people and start sorting them out. And they did something that was, because everybody dies and you especially don't usually have a long life in an insane asylum, they got to see what was really going on in their brains. And so the first description of MS was by this doctor who is one of the fathers of neurology, named John Martin Charcot, who had about he had a bearing that was very similar to our ex-president. and he was a very smart, but a very proud and a very imperious gentleman. But he was a great observer, and he noticed that there were these people who were kind of slow, who had a lot of problems with their eye movements, and they had a lot of tremors, and they slurred their speech, and that after death you could see that they had these hard spots in their brain. And he called this sclerose en plaques, which means hard spots. And it's still called that in French, and we called it in English disseminated sclerosis, which just means a hard spot. And really nothing much happened until it was really described pretty clearly that diseases like this are inflammation. And they figured that out in the early part of the 20th century. A very gifted early pathologist in Scotland who died young because he had TB, and there was no treatment for TB, was able to describe what MS lesions really look like and the characteristics of it, not only in MS, but in other diseases that are like MS. Some of which we don't see anymore. But it took decades for neurologists to really come up with practical ways to figure out what was MS. Why? Part of that is because we had no good testing for it. We had no spinal fluid. We had no electrodiagnostic tests. We had no imaging tests. You want to know how they did imaging? They injected air into your spine, made you do somersaults, and they took an X-ray. How good do you think that was? It wasn't very good. It wasn't a good way. But the concept became what's called dissemination space and time. So you had to have more than one problem at more than one times. And really, as a neurologist, you can only look at the brain, the optic nerves, and the spinal cord. And everything else is in that great gray matter area. Some additional criteria developed over time, about every 20 years, an advance in the concept of how we diagnose MS. And, when I came into medicine, we were using mostly spinal fluid exam. Exam's always been important because this relapse idea has been very important. But not everybody has relapses. Some people just slowly get worse. And you had to do that. But something earth-shattering happened in 1980 is the MRI scanner was invented. And very quickly it became clear there was much more multiple sclerosis than we thought there was, that because you could see it. And we knew that people could live their whole life with MS and not know they had it. And the estimates were it was like 1 in 4 or 1 in 5 people that had MS never knew they had MS. It probably got written off as something else. But MRI criteria were developed by the late 90s, and then subsequently neurology committees started trying to adopt MRI into how we diagnose MS, because it was very clear it was very valuable. And so they said, well, we certainly can see that there are lesions there that we didn't know about. So we want to use it for that, and we want to use it for the new problems to be able to see that. And first, they had these very complicated criteria. You had to have 10 spots, and some of them had to be in these places, and some had to be in these places. And, you couldn't do it only by MRI. And then as they started to test these criteria, they got better and better criteria. And it's gotten down to you only need 2 spots on MRI, or you need 2 relapses, or you need 1 and you have a positive spinal fluid. It's that simple now, and it's still dissemination space and time. It's just your events can be either clinical or MRI or spinal fluid. The big problem in MS is people have a tendency to make this instead of or, they make it and. So they're doctors who, out of the sake of wanting to be as sure as possible, will say, well, I think they need to have these number of relapses, a lot of times more than 2, and these number of MRI lesions, and these, and they had to have a positive CMS. So if you're too strict about your MS diagnosis, you leave a lot of people who are treatable behind. And if you're not strict enough, you might miss something that's really another disease. So this concept of disseminating sclerosis on MRI looks like this. And so you can imagine if you didn't have a very good MRI done, you might miss the whole MRI thing altogether. If you don't have a very good neurologist who does a careful exam or follows you, you miss that part. If you don't have a positive spinal fluid, well, we'll talk about that because some people don't. But you have spots like these around the inside of the brain, or you have spots like the ones in the spinal cord, and you have some spots at times. A minority of people, when you go to look, who aren't on treatment, will have disease where the dye leaks out into the brain. And in the right side of this, you see a spinal cord in the middle, that kind of oblong-shaped piece of tissue, and there is white around the edges of a spot. And that is an active lesion. That's what we call gadolinium enhancement. And you don't see that very much in MS because it doesn't last very long. You only see it when the disease is really raging. This happened to be somebody who was on very aggressive MS treatment, and they still had this, which you usually don't. But most of the spots don't have that. They're old. They're plaques, and there are some plaques that are active, and there are some plaques that are new. But that's dissemination in space and time in one picture. If you get a spot that's not and a spot that is, then you're lucky enough to get it. But that's only a small minority of MS patients get it that way. Most get it by clinical criteria or spinal fluid criteria nowadays. So how does a neurologist tell it's MS and not something else? Well, it's not easy in older people because they have lots of other problems in their brain. They can have tumors, they can have strokes, they can have other injuries. And younger people sometimes have congenital malformations, but the MRI makes it much easier. The story is what's really important in neurologists is the history, and the history of what's happened and how it came about is key to figuring things out, like what's a stroke, which is a blood flow or a bleeding problem, and what's an inflammatory problem that tend to come on more gradually. Not all of them. We're going to talk about one that doesn't. Doctors love to say common things are common. And the other virtue of this is when you hear hoofbeats, you think about horses, not zebras. But MS is a fairly common syndrome. And so that helps us out in making a diagnosis because it's usually MS if it's a younger person, and it does that. When it's an older person, it's usually not MS. But these are, as our favorite author Samuel Clemens said, lies, damned lies, and statistics. They're not always right. And so you have to be systematic of how you go through that. But when I trained, 1% of middle-aged white women in a small Minnesota community had MS, and 1% had optic neuritis too, which we didn't call MS in that time, but now we call early MS when you have optic neuritis. About 3% of everybody in Buffalo, New York, when they go and pull them off the street and do an MRI scan, look like they have MS, but they don't have MS. Why? Because they haven't ever had any events that are like MS, but their brains look like they have MS. In family members of people who have MS. 10% of them who don't have MS look like they have MS. Obviously, these are close calls with MS, that they have the disease process, but they haven't got any symptoms. And we know now about half of those people will go on to have MS. When you're an identical twin, half of the twins will go on to have MS. Fraternal twins are just like brothers and sisters. That rate is very low. It's just a few percent. Children, just a few percent. Why is that? Because the risk of MS is genetic, but it is not a genetic disease. It's less genetic than everything else. Now, in neurology, we try to play the odds. We try to use all these things, but there are other conditions that can make it very complicated. And here on the far right, you see an image of an MRI that has really bad arthritis in the neck that is pinching the spinal cord. And this is a condition called cervical stenosis. And it's a rather common condition. And probably 15 or 20% of people will develop this. And it can cause damage to the spinal cord. And so can other things in there, like benign tumors or large discs. And they can very much cloud the picture because it affects all your arms and legs in a similar fashion that MS can. So it's partly the story. And many times people have to have surgery to figure it out, because that is not good for your spinal cord to be squashed like a banana. And it's not good for your MS. And there are people who are born with their brain squashing their spinal cord. It hangs down. It's a close call with spina bifida or worse. And that is usually benign, but it can squash the spinal cord. It's called Chiari malformation. People have other problems. Strokes are common. Strokes can do that. It can be hard to tell the difference. Other pain problems, migraines. Half of people with MS have migraine. They can really cloud the picture, make it confusing to make a diagnosis quickly. The good news is when people have really aggressive MS, it's usually obvious. When it's sneaking along or poking along, that's not so obvious. So why do you have disagreements about MS? Well, the number one reason is the information available. If someone doesn't have all the information, it's very hard to make an MS diagnosis. Folks who have MS, they talk about what they feel, which is pain and dizziness and fatigue. These are not the bases of these diagnoses. The neurologists talk about lesions, location, activities, disabilities. Those are very hard things that they use to make diagnoses. MRI scans, the quality of the scan varies tremendously. The appearance of the scan actually varies a lot. And the quality of interpretation is enormously different from physician to physician and center to center. So information is key to MS in a diagnosis. And then you add in personal preferences of physicians and how they do things. You have a lot of doctors who say, I want to see big MS lesions. I know a doctor who shows people a picture from Wikipedia of a burned out brain with MS and says, well, that's what MS should look like. They're going to miss about 80% of MS because most MS people nowadays never get that bad, never have brains that look like that. It's very unfortunate if you do. But other people say, I want to see lesions enhancing so I know they're active. Well, that's it's a minority of people with MS. And if they're on treatment, they're almost never enhancing. The one I think is probably most important and that's been dealt with very conclusively through the years, and there's a lot of misunderstanding about spinal fluids. A positive spinal fluid we'll talk about, but there are plenty of people with MS with negative spinal fluids. There are lots of other myths that have been propagated through time. When I started teaching in Nashville, there were still doctors who were telling people that if they had pain, they didn't have MS. Okay, this was never true, but it still goes around. And they were told if you were not Caucasian that you couldn't have MS, and if you had red hair, you had probably had MS. That was one of the ones that went around for a while. And all these things, there's some kind of semblance to facts, but they're not correct ways of thinking. So what other diseases can you have that look like MS? We call them MS lookalikes, and there are certain things that we talk about, red flags, where we're really worried about it. And this is small, And this isn't a comprehensive list. If I made a comprehensive list, it would be 4 slides long. Why is that? Because most of the things that look like MS are pretty uncommon. And we're going to talk about some of the common ones. Children have a disease that's a lot like MS we call ADEM. Why do we call it that? Because it's hard to say acute disseminated encephalomyelitis really fast. In kids, it's usually caused by an infection. It's usually caused by a vaccine. And one of the amazing things, if you are less than 16 years old and you have an MS-like event, the odds are 90% you will never have another one, okay? And if you are 16 years old or up and you have an MS-like event, the odds are 90% you will have another one. Why is that? What happens miraculously at that age? Well, we're not sure, but we know going through puberty is probably when your immune system is done developing. And when it's done developing is when those mistakes count. Now, there's an old disease that is a very distasteful disease to talk about. It's called neurosyphilis. It's syphilis of the brain. It was a horrible, horrible disease, even 100 years ago. I had family members who died from that disease. Very serious infection, couldn't get rid of it. What cured it? Penicillin. Once penicillin came, it almost disappeared. It's still here, looks just like MS. It's very much like progressive MS. And so everybody gets tested for that. You were probably tested for that, whether you knew so or not, when you showed up. Because why? It would be a tragedy to miss that. But it's pretty easy to tell. It's a $5 test to tell if somebody has syphilis, because you certainly need to know. But the test also says if you ever had syphilis, so if you're one of the unfortunate people who had it 20, 30, 40, 50 years ago, your test will still be positive, and that's got to be run down. Lyme disease, just like syphilis, but you get it from a tick. Looks just like MS when it's in the brain. Fortunately, it's very rare and it to be in the brain, and it's very straightforward to treat. But there are people who do have Lyme disease in the brain. There are just not very many of them. The disease we're going to talk about the most here is neuromyelitis optica, because we used to call this really severe MS. And when I started in medicine and in neurology 40 years ago, this was called really severe MS. And the reason why we stopped calling it that was because we finally were able to distinguish it in some cases very clearly from MS, and that it works really differently. And there are medicines that are approved specifically for it, and there are medicines we adopted into using for it. How common is it? It's about 1% as common as MS. And there is a way, we'll come back to that in a minute. Now, there are other diseases that look a lot like MS and are indistinguishable in many ways. And these are usually viral infections in the nervous system. And measles used to cause an MS-like illness, but once they started vaccinating for it, it went away. And PML, which you've heard about, which is an infection in the brain, happens in people who have weak immune systems or cancer. It looks a bit like MS, but it behaves very differently. It's very destructive. HIV and another bloodborne illness called HTLV1 cause disease in the nervous system, which can look a lot like MS or act a lot like MS. Diseases of blood vessels can act like MS. If they're really small blood vessels, they can produce disability that slowly gets worse or suddenly gets worse. It's usually able to tell if it's a more typical stroke-like problem, but there are people who have such slow progressions or have inflammation of blood vessels, it's very hard to tell. These are fairly uncommon that they look like a typical case of MS, but we think about them. There are nutritional problems. 100 years ago, people were so underfed, their optic nerves would suddenly stop working, and they go blind because they didn't have enough B vitamins in their diet, because they ate like sorghum syrup for breakfast instead of real food, or they drank themselves to death in under a bridge. You could suddenly have your nervous system stop working. Even today, we have an immune disease that's called B12 deficiency that many people have. About 10% of people get. that can cause your nervous system to fall apart quite suddenly or quite slowly. It used to cause anemia really badly, but we have so many vitamins in our diet, it doesn't cause anemia anymore. And then copper deficiency, which can actually be caused by taking too much zinc, can also damage your nervous system. And then the compressive things I talked about. But we're going to talk about NMO, which neurologists call it that. Why? Because it's called Neuromyelitis optica spectrum disorder now. And it's a lot easier to say NMO. And a lot of people say NMOSD because that's what the government said, so the pharmaceutical companies had to repeat that. But most neurologists just call it NMO. And NMO is not multiple sclerosis, but it can be very hard to tell. Why is that? It's like saying, is my child average or above average or below average? It can be very hard to tell. Why is that? Well, NMO is rare. MS is common. NMO, it can be non-Caucasians, but so can MS. And there is a test called aquaporin 4, which is a very helpful test when it's abnormal. And that's a lot like spinal fluids in MS, except milder cases tend not to be positive. And the same is true with MS. But aquaporin 4 test was developed by one of my mentors 20 years ago. I gave her the idea, just like Forrest Gump. But she's brilliant. And she developed this test, and it would show the people who had the worst NMO very reliably. And this test is a blood test. It can be ordered. Some people do it well. Some people don't do it so well. But virtually everybody who has this blood test positive has NMO. And virtually nobody with MS has this blood test positive. In fact, if they have it positive, they probably have NMO rather than MS. But the problem is, again, some people don't have positive tests. NMO requires very aggressive immune treatment compared to MS. MS, until the last 10 or 15 years, most doctors were like, well, MS isn't so bad. I still have people who tell me they go to big centers and get told, MS isn't such a bad disease. You don't have to treat it. And, well, that's a recipe for bad MS. But, nobody says that about NMO. NMO is like somebody coming after you with a hatchet. Every time you have an attack, it takes a chunk out of your nervous system. The lesions are large, they're swollen like tumors, and usually they don't have a lot of lesions in the brain, but they can. And the same is true with MS. Usually they have lots of lesions in the brain, but they don't have to, And so there are people who have mild NMO, and there are people who have bad MS. Sometimes it's very hard to tell the difference. In general, NMO hits your optic nerves and your spinal cord, and it has a few other quirks. And some of these things are common, like something called ariopostrema, which is a brainstem attack that causes really unbelievable, intractable nausea and vomiting. We're not talking about a little bit of nausea and vomiting. And it's very clearly not due to anything in people's stomach. So the spinal fluid is usually negative in people who have NMO, and it's usually positive in people with MS. And, MS relapses generally do pretty well, except for really bad ones. And NMO relapses generally do very, very bad. And people with MS tend to get progressive components when they've had MS for a while. People with NMO never get progressive components. They only get worse relapses and often die from their attacks. So it's a very different disease. So about half of NMO patients look like MS for some time before they get called NMO. Usually this is because they have an optic nerve problem or they have a milder spinal cord problem and not a severe one. People with bad problems usually get picked up and nailed as NMO pretty quick, even in places with not a lot of experience. The aquaporin 4 test, if people have a single relapse, predicts very clearly who's going to have another relapse soon with NMO. And this is a very helpful test when it's positive. When it's negative, you still have to be very suspicious. And there are criteria for establishing NMO for people who have negative tests. And it can take years or decades to be sure about somebody who's seronegative, whether they have NMO or MS. Now, there are lots of excellent treatments for NMO. I don't have an exhaustive list here. There are many things that have been shown to work. There are other drugs that are approved that aren't here. But an old drug that we used to use for MS and that many of the newer medicines for MS are modeled on was rituximab, was the first drug that was shown to work really exceedingly well. Before that, we just used immunosuppressive drugs and steroids, lots of steroids. And steroids are like a deal with the devil, as you know, but they work really well for NMO until your body falls apart. There are other drugs that are highly effective for NMO. There is rescue drugs that are anti-complement strategies that block complement and virtually completely short-circuit the disease, although they have risks. And so we always do the same thing with NMO that we do with MS, which is we select drugs that are likely to work, that have reasonable side effect profiles for how bad the problem is. When people with NMO have an attack, not only do they get steroids, but they get plasma exchange, which is where they take the plasma component off your body, because that's where the factors are, the antibodies and the proteins called complement that are involved in destroying the brain. And if MS is like an invasion, NMO is like a nuclear war in the brain. It just completely lays waste to the tissue. And it's very, very different strategy than MS. All right. Well, that's I think, if you have questions about NMO, I want you to write them down and we'll talk about them at the end. But what is the spinal fluid issue about? Spinal fluid with MS usually has problems we call elevated oligoclonal bands and IgG index. What are these? These are proteins that are present, that are made by immune cells, which are packed into the brain. They're just lined up in the linings and all through the brain. They're cells that have migrated in there, and they're being driven. And not only are they being driven by the inflammation, they're driving the inflammation. And they're called plasma cells. It's an ancient term. It has nothing to do with plasma. They are the cells that make antibodies as factories. And we aren't really sure what they make antibodies to. It doesn't seem to be anything important. But they keep the immune system revved up. I like to say that these cells are the cheerleaders, and we can't get rid of them. You know, they don't go away easily. The cells that they come from, we can make go away. But once those cells are there, they're very hard to make them go away. They were long ago, even in the 60s and 70s, recognized as a bad prognostic factor. And we use them as part of the criteria for MS diagnosis for a long time. But long ago, they realized that there were people who had MS who didn't have these cells lined up in their brain and spinal cord. They had smaller lesions, and they didn't have these abnormalities. And that's always been the case, that spinal fluid can only say yes, it can't really say no. And this is a hard concept for many physicians and patients to get, that a large fraction of MS patients today have negative spinal fluids, especially early in their disease. That's probably not the case in long-standing severe MS. It's probably over 95%. And what's really strange is that it's very different at different latitudes. If you go far north, it's a really great test. They use it to say, no, this person doesn't have MS. If you go really far south, it's a completely bogus test. You might as well not even do it. But if you get in a temperate latitude like this, it's usually abnormal, about 70% of the time. So it's helpful. It probably says something about how bad the MS is. Right now, it's used to sort of say, this has been going on a while, that it's not something that's going to go away. We can often say the same thing about looking at MRI scans. If there's a lot of spots, they didn't all get there recently, but they can be very old, and you don't know if it's still changing. But if you have a positive spinal fluid, we say it's changing. So if you've ever heard one of my talks, you know I love this video. This is a video from the 80s that was done. And this is a picture every 2 weeks on MRI of somebody with MS that's having no relapses. But what are they having? These are episodes of inflammation that are coming and going in the brain. And there are a lot of old lesions in the middle that you see that aren't very bright, and you see these lesions that come and go that are very bright. This is the inflammatory process. This was the epiphany of understanding what was going on with MS. The MS wasn't a disease that came and went. It was a disease that was there all the time, and it was clinically silent. And this is part of what we're treating. Let's go on to the next slide. The other thing we're treating is to try to protect the brain. And this is the process over many years of what happens with just a little bit of disease activity that people have, where the brain shrinks away because of the damage that's occurring from that other process you saw, the chronic inflammation. Okay? So we're going to talk about some of the MS symptoms and how to treat them. There are many MS symptoms that I'm going to leave out because it's just too complicated. But one of the great things is that there are so many specialists involved in caring for people with MS now that are good at what they do. The urologists who are good at helping with bladder issues, which continue to evolve with things like Botox and stimulators, the people who can treat mood and pain and all the other comorbidities that come along with MS, and sleep physicians, because sleep is such a big part of MS. But people with MS every day have to struggle with a number of symptoms, and the foremost MS symptoms really come from the part of the brain that's above our ears, which is fatigue and cognition and mood. And mood is a fairly straightforward thing to treat, and there's a lot of people who know how to do that. We're not sure what the best way is to treat some of the other symptoms. We know some of our MS therapies are very helpful. Eye nerves are mainly treated by prevention and rehabilitation. Problems with your balance and vertigo, there's some very straightforward ways to do that. Everybody would love to sell you a hearing aid if you had a hearing problem, but most people with MS don't have that much more hearing difficulties than anybody else. And if you have bad MS, you probably have some of all these problems. Our phrase in neurology that we use to talk about problems with MS is what is lost is not usually regained. That's not always true anymore with highly effective therapies. We see people get better. We see people get better that had no business getting better. Fatigue is the number one MS symptom. Everybody has fatigue. There are many contributors to fatigue. Pure MS fatigue usually follows your daily rhythm of when you would get tired anyway. Fatigue is usually the number one complaint. MS fatigue components are usually more lazy than sleepy. And sleepiness is treated differently, but it, of course, contributes to the situation if you have that. Our newer disease-modifying therapies are definitely better on fatigue. People feel better. They can feel they work. In fact, some of them work so fast that people can tell that it's actually the MS medicine that helps them. Mild stimulants are still often used because some people feel more alert and able to function better. Stronger stimulants are amazingly not necessarily better. And there are things that may be tried, but usually don't always have predictably better effects. So the usual MS complaints are pretty fine when people wake up. If you don't feel rested when you wake up, you usually have a sleep problem. And it gets worse, and it's more of a motivation and fogginess. So it's hard to tell what's the bigger component. Where is it cognition, able to sort through things, or is it fatigue? It's usually worse in the afternoon. And some people report very remarkable improvements in the evening. We think that this is probably related to body temperature, which is very low in the mornings, climbs throughout the day to the afternoon, declines again in the evening. And unlike what you were taught that body temperature is 98.6, it's really not. It's like 97.5 in the morning and like 99 in the afternoon. And there's really no correlation with MS fatigue and MS lesions. It has nothing to do with it. It has much more to do probably with the inflammation. So the other problems in sleep that can contribute to MS fatigue are trouble sleeping, like your dog, your spouse, your trouble falling asleep because you're worried, your breathing problems while you're asleep, or if you have brain damage that causes your sleep not to be right. That's called narcolepsy. It actually happens in an MO too. So all these problems can do that. People's bladder can wake them up. People's pain can wake them up. Their restless legs can make them up. Restless legs is about 1 in 3 people with MS. It's their biggest complaint. Your mood can affect your sleep. Your thinking can make you, if you wear out, you can have trouble. And many people with MS are still quite sensitive to environmental temperature. Back when I first started in MS, the big thing was NASA had invented a spacesuit for people with MS that was basically a chiller that kept them cooled down. That hopefully is not necessary as much anymore, but people with MS still enjoy a cool environment and exercising in cooler temperatures. The big thing that's the doctor's problem is a lot of medicines we use to treat one problem cause another. And those are anything that makes your mouth dry or makes you sleepy is going to make your thinking and your fatigue worse. This includes a lot of bladder medicines. It includes a lot of mood medicines. And there can be a lot of looking around to find the best medicine to do something without making another problem worse. The heat sensitivity, it can be due in part to medications that diminish sweating. People with MS already don't sweat normally. They often don't sweat in the lower part of their body normally. They often say, I sweat really bad. And it's their head that sweats because the rest of their body doesn't sweat normally. And that sweating can also be diminished in the normal response, much like hot flashes, because of the difficulties with medication. Having spasticity, which is this abnormal muscle tone that occurs in the nervous system, makes your body work really hard to produce more energy and consume energy, which raises your body temperature. Exercise normally raises your body temperature to 101 or 102 degrees. So trying to deal with fatigue, it's all these things. And it's an ongoing dialogue to deal with managing your fatigue. Energy, we used to talk about energy conservation. Well, some people with MS really have to conserve their energy. But we've learned that in fatigue in general, that if you get out and move, it actually makes your fatigue better. And that wasn't the case that we used to think that, but that's very well established. So restless legs, easy to treat if you got that. Sleep disordered breathing, easy to treat if you got that. You often need a sleep study to figure that out. Antidepressants, you can get that at a family physician now. Your neurologist isn't going to do everything for you. Your neurologist is going to focus on the nuts and bolts of your MS. People who have bladder problems at night, there's a million things to do for you. It's all important. And a lot of times you can leverage the use of some medicines that are very well tolerated and safe to treat multiple problems. If you're one of these people who has to work with fatigue, you have to schedule your work creatively. You have to control your environment. If exercise is very important, it actually makes fatigue better. But if you wear out, you've got to work in a cooler environment and exercise. Stimulants are helpful. What's the best stimulant? The best stimulant is caffeine. By far. In fact, people who drink a lot of coffee have much milder MS. The Swedes swear by it. They have great coffee, so they drink a lot of it. But there are old safe medicines like amantadine, and then there are newer stimulants like modafinil and armodafinil, and there are old amphetamines. There's an old amphetamine called phentermine that's used for weight loss, but it's actually an amphetamine. It's just a safer one, and it's less strong. It has less side effects. The other thing that people with MS need to remember is we have a drug that makes a lot of things better, but because our government loves to hold the feet to the fire of pharmaceutical manufacturers and extract cash from them when they get out of line, won't let them talk about everything that their drugs do. But this old drug called dalfampridine
which used to be called 4-aminopyridine. They changed the name because it's bird poison. But dalfampridine is called the walking pill because that's how it had to be marketed. Even though it makes a lot of things better, you can actually measure it with a stopwatch on how fast people walk. And it improves the conduction in these damaged areas. It also does everything. It makes your muscles stronger, period. Nothing to do with how it works in the brain. It makes your brain more awake, period. Nothing to do with the demyelination. It does all these things. That said, it doesn't work for everybody. It only works for about 2/3, and 1/3 look amazing, and 1/3 it's okay, and 1/3 it just doesn't do anything, and you can't use it if people have epileptic seizures. But this drug is now $15 a month at discount pharmacies. It's amazing. If you haven't tried it recently and you got problems you're struggling to overcome with MS, it's a really good drug to try. The risk of seizures is less than 1%. Let's talk about cognition. That drug is actually used for cognition too sometimes. So cognitive impairment is a complaint of pretty much half of people with MS. It's actually the more common reason people have to stop working. Difficulty problem solving, performing routine tasks, and I think people with MS perceive the effort they have to put out to do it. It's much more like you're at the end of the day trying to do the job than it's just not easy to do these things. They can do them. They actually do them fairly well. They don't look terrible. They look slow, and they look like they make more mistakes. But these kind of complicated disturbances lead to mistakes. Less commonly, people really have disturbances with their language. Most people say they have trouble finding words, but they find them. There are some people who can't. Personality issues, sometimes dramatic changes in people's personality. That's not common. It's really not. Mostly, it's very subtle abnormalities, which are hard to distinguish from everybody else, but they are distinguishable. If we get out a stopwatch and we keep score when you're playing games, we notice. That's how it is. It's very different from the senile dementia, which we're working on trying to treat that now. I would say that it's slow and fuzzy thinking is the best way to think of it. And it's really highly correlated with the amount of brain atrophy there is. And nobody likes to talk about shrinking brains. I showed you the incredible shrinking brain slide earlier. But basically, the more space inside your brain that's not brain, the slower you're going to think. That's true of your grandmother, too. But people with MS are losing brain when they're not being treated 1 to 2% a year. That's way, way faster than normal. That's 5 to 10 times faster than brain normally disappears. So this is why treatment's really important. If there's no other reason, it's to protect your thinking. Making sure your MS is controlled. That some of our drugs have really good data about this, and about mood and fatigue and cognition. You're not allowed to hear a lot about that in company-sponsored events or online because those are not government-approved indications. But they're out there. They work. We have the stimulants that help. Surprisingly, really strong stimulants don't make people pay more attention. Donepezil and retigaine are drugs that were approved for Alzheimer's disease. They actually do help memory some. And there are all kinds of things that need to be tried. If it's something that's really in your way, if you are having trouble with your gait and you can't take dalfampridine, the next drug you should try, again, is this old medicine called amantadine that we talked about for fatigue, because it makes people walk 25% faster. We've seen it with a stopwatch. The government said, not enough to make us approve it. But for some people, that means some people walk 50% faster and some people walk 10% faster, and nobody really cares about 10%, but 25% is pretty impressive. And you will notice it. All right, let's talk about pain. Pain is a big issue. Remember, people with MS don't have pain. That was literally what chairmen of departments were saying 30 years ago. And it's false. It was never true.
trigeminal neuralgia being the most classic example of a really painful MS problem. But people with MS not only get sensory dysfunction that's caused by the MS, they also don't feel pain the same way as everybody else. They feel it more intensely. And because people with MS do get everything that everybody else has, they certainly get more spine pain because of the amount of force put on their spine by the spasticity. But they get unnatural and deep pains that they can't put their finger on where it's coming from. They get the same kind of problems that are common otherwise, like fibromyalgia and back pain and carpal tunnel and so forth. But these kinds of pains have to be distinguished and treated individually. But nerve pains are generally either unnatural, touchy, burning, stinging, electrical. It may have one of those features. Those are fairly typical neuropathic pains. And they're called neuropathies, just like we talk about neuropathy in their feet, but they're not in the feet. They're in the spinal cord. They're not like diabetic problems. And they often describe it very unnaturally, and the most common typical thing is people talk about the MS hug, where they have a very unpleasant sensation that something is too tight. They're wearing a garment that's too tight. But all these are responsible to treatment in one way or the other. And there are many things. There are even things that aren't medications. There are electrical stimulators. There's very helpful over-the-counter products that can be used. And really, the thing that's important is that opiates really don't do better than non-narcotic medicines. The non-narcotic medicines are usually better both in the short term and the long term once you get it right. But being on treatment for MS is really important. Pain is not an indicator of how bad your MS is. In fact, this drives a lot of changes in medication that are unnecessary and may even be unhelpful because people think they're hurting more because of their medicine. They're hurting oftentimes because their sensation is improving and they feel things in an abnormal fashion now, but actually the problem's calmed down. And this is one of the strange things that many of our effective MS medicines have limb pains and back pains listed as side effects. All right. The typical medicines, anticonvulsant type medicines, of which there are a bunch, non-narcotic painkillers, of which there are a bunch, antidepressants, of which there are a bunch. They generally are called SNRIs, the one that work. Acetaminophen, believe it or not, people forget about it. It actually works for a lot of people for nerve pain. It's actually like a little bit of cannabis. A lot of people are taking cannabinoids nowadays. They're legal in some forms in most states. What's been shown is they really reduce more the attention to pain than the amount of pain. But that's fine if it's safe and effective, and those need to be talked about with experienced people in this state where I practice. There are drugs that are out there that we don't have a lot of confidence in them, over-the-counter drugs that haven't been adequately vetted and done. And people can overdose themselves on them. It happens all the time. A few times a year I get a call from an ER about one of my MS patients who's overdone it with a cannabis product and is out of their head. It happens. And, unfortunately, there are good aspects to many medicines, but there are ones that have to be respected. Vertigo is a big complaint for MS. It's not always due to MS. Everybody gets some kinds of vertigo. But this kind of constant queasy, head floaty, rocking or moving, overreactive thing can go on for many weeks. It's often misdiagnosed as another problem. Sometimes it is another problem. It's very hard to tell it's another problem. Over the counter, you can buy meclizine now. You can buy huge amounts of meclizine for a few dollars. And there are other drugs that are more effective than that are prescription drugs that work the same way. There are exercises. There are older drugs like diazepam or clonazepam in very small doses that work. The problem with medicines like that, like Valium, like medicines, is they are the most sedating and impairing medicines you will deal with generally. And so you don't want to have to use those unless it's really required. What is spasticity? Well, our friends in Great Britain call people with cerebral palsies the spastics. Okay, we don't do that in the United States. We call somebody spastic when we wanted to say they were clumsy. But spasticity isn't clumsiness, and it isn't cerebral palsy. It's injury in some of the pathways in the brain that loses control of the control of muscle tone. And so what happens is the muscle tone becomes controlled by the spinal cord. And the spinal cord is good at following orders to go and not to stop. That's what lets you stand there and not think about it, or hold on to something and not think about it. Is once it's there, the brain says, okay, and the spinal cord takes over and keeps the muscles the same. The problem is if the muscles are always on, they get bigger and stronger, and they fight each other, and they don't stop. Sometimes they even jerk back and forth, like dueling banjos that are dueling reflexes, and you get this jumping in your leg or arm in. This is a loss of voluntary control and the ability to turn off these reflexes. A limb will get stiff, and really it's being trained not to relax. And the biggest muscle will win, and it will keep pulling on things till either tendons get short or sore, or the joints get sore. And spasticity is very different from nerve pain. People with MS often have a lot of problems in a limb, and it's hard for them to tell. To them, it's all the same problem. But it may be more spasticity if it's pulling on a joint and a joint is sore or a muscle is sore. Hamstrings are a good example of muscles that get really sore when you sit and you stand, and it hurts, and it won't stop relaxing. But neuropathic pain is usually over a bigger area, or at least more distally in the limb, farther down in the limb. But spasms happen a lot when people have spasticity. And medicines are out there that help all these things. But most pain that people with MS have is not spasticity. And many times attempts to try to treat the pain as spasticity are really unsuccessful. Although some of our medicines for spasticity work for pain. Baclofen, tizanidine, very helpful medicines for pain. A lot of people pursue surgery or Botox trying to treat nerve pain, and it doesn't do anything for nerve pain. But spasticity becomes really important to treat when you're beginning to have obstacles to your walking or your activities of daily living, and more intensity. A lot of what we consider to be secondary progressive deficits in MS are actually due to spasticity. Because the spasticity can be reversed. Spasticity can be retreated. It's a question of what lengths you have to go to get that done. And sometimes you have to treat the spasticity just for comfort. Cannabis products are approved in much of the world for treating spasticity. Our government has chosen not to approve cannabis products in the United States for spasticity because they don't do a lot to it. People feel better, but you can't see it makes it better. They will check a box that it's less, but when somebody else looks at it, it's not any different. So that's why they haven't gotten approved in the United States, but they are available in other parts of the world. And certainly cannabis products are available in the United States. We're not a big fan of them because you don't know how much is in there most of the time. And, it's illegal in a lot of places. And whenever I ask a patient, well, what exactly are you taking? They have no idea. They can't tell me a name brand. They can't tell me how many milligrams. I have no idea how to treat somebody who I don't know what they're taking. I mean, it's kind of like saying, here, take a swig of this and tell me what you think. It's the same way when you deal with cannabis from a lot of places in cannabis products. And some people overdo it, that's for sure. And it's not, large doses of cannabinoids are not good for your mind. So you have to respect very carefully what the risks are. Most of the medicines that are approved are very straightforward. There are a lot of medicines out there. This is more of a laundry list, but you can separate it into oral medications, toxin injections, and intrathecal therapy, which is usually baclofen in a pump. You don't usually go to these more difficult things like surgical solutions unless you've got a really difficult situation. Toxin injections, which is Botox, or botulinum toxin is one brand. There are several others. Some have more bang for the buck than others. It gives you good control over certain overactive muscles. If somebody's got horrible hamstrings or a horrible muscle that's making their foot go into a bad position, it's a very helpful way to do that. It does have to be repeated periodically. In the beginning, it's more frequent, like 3 months, but some people, it can go years without in between. Stretching, however, is the number one thing that you have to do for spasticity. It's the cheapest, quickest, most important, most neglected method. You can learn it from a physical therapist, or you can teach yourself just by a self-study, and there's a lot of good programs on the MS Views channel. It's best done by yourself at home or with family help, and it's best done several times a day. Medications do not replace stretching. If you don't stretch, you're going to get more immobile, more contractures, more joint destruction, and poorer function. You'll use a lot more energy and be more limited because of tight, stiff muscles that get in your way. You don't have to worry about baclofen pumps unless the biggest problem you have every day is spasticity and you don't tolerate everything else. And it really pretty much is limited to working on the legs. There are orthopedic surgeries that are done for spasticity. They can prevent a foot from turning in or a foot drop that is caused by pressure, by forcing the foot down. And there are sometimes they just have to cut tendons or nerves if a limb's not useful. That's very rare nowadays. I'm going to stop there because the bowel and bladder are a really big topic, and I will let Stuart here. Is he still going to do questions? Just let him know I'm finishing up. But I will say the most important thing about MS symptoms is you want to work on one thing at a time when you're working with a physician. You want to pick the biggest thing that's important. Now, if the biggest thing has always been spasticity and you haven't found what works or works well, you need to pay attention to smaller differences because most of these things help some. If you tried everything for fatigue and nothing did it, you either have more than one kind of fatigue or you were hoping for more than you got out of medicine. So you want to find out what works. I mean, there are some people I'm like, the kind of fatigue you have, you really should learn to drink coffee. I don't want to drink coffee. Okay, well, that's fine. That's what you paid me to tell you. But, there's a lot of ways to solve problems. And you need to try to find the best way for you. All right, Stuart?
First, I wanted everybody to give you a round of applause for speaking. My gosh. You caught me off guard because you ended early again. All right.
I didn't end early. I gave you more time for questions.
Okay, thank you. Who's got a question in the room? Otherwise, I've got a lot of questions online. Anybody have a question here? Raise your hand. You can't have come here and not have a question. Seriously? All right, here's one for you. When they find Dawson's fingers, is it always about multiple sclerosis, or could it be related to another disease?
That's a really great opinion. So Dr. Dawson was this Scottish pathologist who was rather brilliant. I've got his book. I should have brought it to show you. It's beautiful. I've got one of the few copies. I buy them up whenever I get a chance. But what Dawson's fingers are is these oval oblong areas where the inflammatory cells have scarred the brain and they come out of the blood vessels deep in the brain. And so it looks like these growing abnormalities out from the middle of the brain. And they recall that, I think they named him that in honor of him because he was the one who described that as a typical evidence for inflammation in the brain, not just for MS. He actually described it originally in a disease called SSPE, which we neurologists like these terms because it's subacute sclerosing panencephalitis. It's actually a measles infection in the brain. It's very rare. I've seen a couple cases in my life, but they don't happen much anymore because people get vaccinated, so they don't get this really rare kind of measles in the brain anymore. But Dawson's fingers happen for when people have inflammation as a child. They may get ADEM, this kind of one-time event, and they're scarred up for life. I see people who are 80 years old who come into the hospital, have had a stroke, and we're like, holy cow, does this person have MS? And like, no, they don't have MS. They've lived their whole life, and if they have MS, they don't know it yet, and neither does the neurologist, but they may have Dawson's fingers in their brain, even though they don't have MS. So, yeah.
You've probably covered it, and I missed it, but the absolute origin of MS, I mean, I can follow you back as far as the inflammation gets into the central nervous system and causes sclerosis. But where does the inflammation come from? I mean, is it in the DNA where some people are susceptible to things they eat? Is it an allergic reaction?
That's a very good question. And the simple answer is it's bad luck. No, but I don't mean to be facetious. But where does it come from? This is what we're struggling with and trying to understand. I will tell you, we can produce these diseases in experimental settings purely by giving the immune system a signal to say, go fetch that, and it will cause the whole problem. You give them a brain protein as a signal that says, go boy, and the immune system will attack and cause the disease that's indistinguishable from the MS. How does it happen naturally? It usually happens from a virus. We have viral diseases that that animals get infected with, and they cause in the animal a disease that looks just like MS, and we know the virus is there. In people, we can't find a virus there, but we know everybody with MS has a virus called Epstein-Barr. Every 100%. 100.0%, 99.9999999% have this virus, and they always have it by the time they get diagnosed with MS. We know that virus is a very crafty parasite of the immune system. Most people have it. Most people control it. People with MS control it, but it takes a lot of response to control it. They have massive inflammation against that virus. And this virus causes other problems too for people, but it causes other immune diseases. But we don't understand how that translates into start of MS. But we know people with bad infections with that virus are 50 times as likely to get MS, all right? So we know that there's a big connection there. And there's experimental data going on about this. They're trying to find a way to control this virus. Because it's not fully controlled in people with MS. But it's not like the brain's loaded with the virus like it is in some immune diseases. But we know that the immune system can cross-react when it's attacking a virus. It can attack normal tissues. The thinking is that's how it starts, is that's what sends the cells to the address in the brain originally, looking for the virus. And they smell the brain instead and start getting sucked into the brain. We know that there's a lot of people that this starts and it doesn't go on to symptoms. Those are the close calls with MS. We see people, we get an MRI scan for some other reason, and we say, wait a minute, does this person have MS? No, they don't have MS. Well, they don't have MS yet. They may get it, they may not get it, and the odds are about 50%. And so there are probably twice as many people walking around out there that look like they have MS than actually have it. But they obviously have the same kind of problem. It's just not as bad. And some people with MS have very small number of problems. They're just in the right place to really cause difficulties.
All right. Person is asking, let's see, can you explain how low-dose naltrexone has helped people with multiple sclerosis?
That's a good question. And I didn't include a lot about no-dose naltrexone. I should put it in there. So naltrexone, let's talk about naltrexone. Naltrexone is a drug. Do you know what naloxone is? Has anybody heard of naloxone? It's a drug that you run around and inject people who are overdosed with opiates. Naltrexone is an oral version of that type of medicine. And it was developed to try to keep people abstinent from IV drugs, and it actually worked very well for alcohol as well. It's still used in some places to treat alcohol addiction because the endogenous systems that are involved in addiction are very much dependent on the internal morphine-like signals in our brain. So what does low-dose naltrexone mean? Well, the drug works a little differently at very low doses, and it can activate some pathways. And nobody's entirely sure because when a drug is cheap and safe, the amount of research that gets done with it is very limited. But what is known is that people with a number of immune conditions say they feel better when they get small doses of naltrexone. The evidence that they function better is very poor. So, is it a good treatment for people with MS to try? Well, there's not enough data to say how reliably it works. There is data to say, well, some people say it makes them feel better, and it is a very safe drug. It does cost you something if you get these well-prescribed, 5.4 milligram or these off-ball amounts that have to be compounded by a pharmacist. Probably doesn't matter whether it's 5 milligrams or 10 milligrams. It's sold in pills that are 50 milligrams. So all the pharmacist is doing is grinding up a big pill, weighing it out, and putting it in a smaller pill for you. You can do that with a pill splitter. And naltrexone is also approved in low doses as part of medicines that are used to control binge eating, which for weight loss in similar doses. And there's a drug that's approved and on the market that has a combination of antidepressant and low-dose naltrexone. So that it's safe, there's no question. That it can be tried, well, we don't have good evidence for when to try it. If people want to try it, I tell them to try it. We can give you a 50 milligram naltrexone pill and chop it up into quarters or eighths and see how it works. Most of the time people tell me, it didn't do anything. Wasn't because it wasn't 5.4 milligrams. It was because it didn't do very much. But when you test it precisely with people usually say it works. Well, people say the same thing about antidepressants. I think it acts more like an antidepressant than it does act like a treatment for MS therapy like our other MS therapies.
Somebody has a phone ringing.
It's an alarm.
Oh, it's you. Oh
yeah,
my
it's
gosh.
an alarm that
No,
doesn't.
You're
can't
docked.
be shut
You're
off.
docked. You're docked. Okay. All right. Here's another good question from online. Why do people with MS not perspire?
Well, the pathways in the nervous system that drive your perspiration start in the brain, and they're little tiny cells that go all the way down your spine, then out of your spine to other nerve cells that go down into your limbs. They actually follow all your blood vessels out to your skin. And this system is driven very reflexively. You don't think about it. You don't say, I want to perspire now. It's automatic. And it's driven by lots of body temperature related things and physical activity and whether you're eating and so forth. But people with MS have damage in the brainstem and the spinal cord, and sometimes it interrupts these pathways, just cuts them, and they're not there anymore. And if you do a sweat test, if you paint people with MS, especially who have difficult MS or disabilities, with a sweat indicator, you can see that they don't like sweat on certain sides. They'll be different on each side, and there'll be different levels, and this limb won't sweat. And that's why they don't sweat. They want to sweat. And a lot of people with more difficult MS do not regulate their body temperatures well because of this. They get dangerously overheated, or they get very low body temperatures. And some people with MS get confused because their body temperature gets so low. It gets down to 94 or 95 degrees, and they don't think clearly. They don't work well. They can't do things. How do we treat that? We put clothes on them. We put more clothes on them. It works pretty well. But the big danger about not regulating your body temperature is very easy to get heat stroke. I probably had 4 patients die from heat stroke who had MS. They go outside, they get hot, they can't think clearly, they can't get out of the sun, they can't move, they die. their body temperature goes up to 107 or 108 and you don't survive it. It happens a lot with people with MS, and it's very dangerous. And I tell people with MS, don't go out and don't stay in the sun. That's how they die.
All right, great. Next one says or asks, will primary MS always go to secondary MS?
Well, that's a good question. What does primary MS mean? And primary progressive MS means MS starts as a progressive disability, and secondary progressive MS starts as relapsing MS. It's called secondary because it was not progressive and it becomes progressive. And so primary progressive MS does not become secondary progressive MS. It can have a relapse once in a while. You can be watching it and all of a sudden, oh, they never had that before. They have a relapse. But usually they just slowly get worse. Those people usually are older, they have smaller lesions, and they have spinal cord type deficits. Secondary progressive MS is what almost all people who have significant MS that started with relapses get as they get older. And we call this generally active secondary progressive MS because pretty much all the experts agree there's very little inactive secondary progressive MS. When you look at it, it always changes a little bit over time. And whether it's a relapse or a new MRI lesion or a MRI lesion that's getting bigger. So secondary progressive MS is part of the relapsing MS spectrum. Our regulators and the government really helped us out when they basically endorsed that relapsing MS means you've had a first symptom or you've had relapses before, regardless of whether you have progressive components, which are usually leg-related or cognitive to your MS. And primary progressive MS just means we've never documented that you had a relapse. And you're slowly getting worse. And those some of them will go on to have relapses, and some of them don't. They're very infrequent compared to the other people. And in secondary progressive MS, the relapses are much less frequent than people usually had earlier in their disease course.
Thank you. Next one. Tell us about mRNA and the likelihood that something will come about for an mRNA vaccine for MS.
mRNA is a very fascinating. There are different kinds of mRNA strategies for treatment. What is mRNA? mRNA is the message your cells use to make proteins, but mRNAs can also be used to turn off other RNAs. These are called small interfering RNAs. They basically are basically like they sit in a pathway and block a message being made. So an mRNA vaccine, and there are some that are being tried for Epstein-Barr virus right now, because it's a new technology and nobody's tried recently, and it's very expensive to make the older style vaccines, but it's very inexpensive to make these mRNA vaccines. These will be tried. There are other ways to reduce cytokines. If they wanted to treat MS with interferon beta, they could make a genetic treatment to do that. However, while those medicines were very valuable at one time, we have much of things that work better now. And so we use them. We don't know what's going to happen. You don't know in medical research what's going to be the outcome until you see the outcome. There are drugs that are RNA-based that have been invented for cholesterol recently that are freaking amazing. You get one injection every 6 months, and your cholesterol problem goes away. In Britain, they actually guaranteed it would work for people, or they didn't have to pay for it. That was really good to our friends in Britain who like to save money, and so they were able to sell their drug there first in the middle of COVID before they came to the United States, and people just had to pay for it.
I want to know what determines when you need to have additional imaging. Is there a time frame that you should be imaged, like your brain and your spine?
That's a good question. The answer is it depends. So people who have had Stable scans are usually not imaged very frequently. First of all, why do we image people? The most important reason is we see things we need to know about, all right? Now, when you're talking about the brain, that's most of the brain. We can't tell what's going on there unless we get an image. Now, if we've had a couple images and they were pretty stable, we're not in a hurry. If somebody's on good treatment and it seems to be working, we're not in a hurry to do another picture. As people get older, these changes are very gradual in most cases. You don't tend to not see new problems, you see old problems get a little worse. But in people who've had activity previously on MRIs or have changed treatment, we're going to be wanting to be able to be assured that there aren't silent changes that are coming along frequently. That's why we do head imaging. We do spine imaging for two reasons. One is for diagnostic purposes. The other is there are other problems that go wrong in the spine, and they look just like MS. And so we look at that. We come back periodically. We do that much less frequently in the head than the spine. I once heard a horrifying lecture by a colleague talking about how much money his academic department made by imaging people with MS all over their nervous system twice a year. I thought it was the most scary thing I'd ever heard because it's completely unnecessary, except for a small fraction of people who really have aggressive MS, where you are constantly working to try to stop it from getting worse. Those people you need to image every 3 or 6 months if it's a life-threatening level of inflammation until you get it controlled. And then you only need to scan every once in a while to be able, once you know it's controlled, you may need to scan every 3 to 5 years to once you know that it's stable. There are a minority of MS patients who don't have a steady level of inflammation where it periodically comes along and gets out of hand. It's always a surprise when you see that, but it's a small fraction. The average patient with MS, it's pretty linear. The amount of disease activity you have has to do with how well you're treating them. But there are other people where it's just periodic and it pops up once in a while, and you don't know who those are going to be until you happen to see it happen. So there's no hard answer about how frequently scans should be done. I personally choose to do really good quality exams at key points in time I need them. The problem is when people go into an ER, they say, well, I think I'm having an MS relapse. They go into an ER, and what usually happens is they do some very quick MRI scans that are meant to look for strokes, and they tell them, oh, nothing's wrong. You don't have MS after all, because they did such a bad scan. And then the insurance company, when somebody else wants to do one, comes along and says, oh, well, you had an MRI scan last year, so when your doctor wants to get one, oh, we're not going to let you do that because you just had one. You had a crappy MRI scan in an ER. Well, if you have an emergency and you can't see or you can't pee or you can't walk or you may have a stroke because you can't talk or you can't move your arm, you need an MRI scan right now. But otherwise, you need an MRI scan done at the time your doctor thinks. You don't need an MRI scan done when you have a relapse if it's clear that you have a relapse of your MS. If something is horribly wrong and your doctor needs an MRI scan, well, you can certainly do one. You certainly don't need it before you get treated for a relapse. And if your relapse is really severe, you may get an MRI scan as part of that evaluation. If you're on a drug like Tysabri, natalizumab, which is about to have a biosimilar of a different name, that MRI scan may be done to watch for a rare brain infection that occurs with that, which is not that rare with Tysabri. And so if you have a new problem, you may get an MRI scan every time you have a new problem on that drug, but not with other drugs generally.
Thank you. Before I go on to any question online or in person, I want to ask you a question you're going to have to evaluate some of your colleagues, all right? Some of your colleagues say that it's time to stop using your medication only when you die, all right? In other words, everybody, there are a lot of people that ask, do I ever have to stop my medication? And there are certain neurologists that say, yeah, when you die, you'll have to stop taking your medication. All right. There are other neurologists out there that feel that when you reach a certain age, not that you don't need it, but that if you haven't shown a relapse in X amount of years and you don't show a worsening on your MRI and you're over 65 years old, then maybe it's time to stop. So which is the real answer?
Well, I will just say I see a lot of patients that someone tells them they don't need treatment for MS, and they come to see me and they have had a major complication of their MS, at least in part because they stopped treatment on the advice of a physician. That isn't everybody. And my personal criterion is if absolutely nothing has happened for 10 years and you are over 65 years old, and I can't tell you how rare that really is when you have the records, that nothing has happened in the last 10 years that was an MS activity. Because people always come in and ask me this, can I stop my treatment? I heard I could stop treatment. And I say, you got steroids 3 years ago because your leg didn't work. Do you really want to stop your treatment? Oh, I didn't remember that. But I have other doctors who go in the room and say, you're over 50. You can stop your MS treatment. Nothing's, you've been fine, right? Okay. And they don't even remember. And I get their records and I look at their MRI. Their MRI is a mess and it's still changing. And they just stopped their treatment because somebody didn't have the information or didn't bother to find it out. I think that happens a lot. I think it's a real problem. I have colleagues who are more religious about stopping treatment than they are about science. And you know what? Everybody hates all the work that it takes to keep people on treatment and treatment people. I'm sure people hate paying for it. I'm sure people hate doing it. There are now treatments that cost $50 a month. Okay. If you want to try something cheaper, you can't get it paid for, try something cheaper. But don't risk your whole nervous system. You know, anybody here a high school football fan? Nobody would walk off the field in the fourth quarter when they're ahead. You know, you don't quit when you're succeeding. What is the risk? Are there certain medicines that have risks? There sure are. And your doctor needs to go through those and figure out what to do with you. There are a lot of safe, effective treatments, and you got a lot to lose, and you want to die on your feet. You want to die walking if you can do it, you know, and, you know, I've seen too many stories where somebody ended up disabled, horribly because they stopped their treatment, you know, and one bad relapse is all it takes to do that.
Next question. Can you tell us why BTK eyes are not yet FDA approved?
Because nobody's proved that they work for MS. But the BTKIs don't have anything to do with the serial killer. They are medicines like the newer medicines that are used for cancer that aren't chemotherapy medicines that turn off signaling systems. And they are anti-inflammatory medicines that are being tested for MS against other MS medicines to see how well they work and what their safety is. They're about 3 years away from the market if they work well.
Okay, thank you very much. All right, next one says, can you speak about diet and the impact on MS?
And diet has a big impact in many ways on people with MS and their bodies. First of all, I will say that being overweight is a big risk factor for MS and makes MS worse because it causes inflammation in your body, and it also makes you have to use a lot of energy. Actually, being overweight as a teen is a risk factor for getting bad MS. But the quality of diet is an important and evolving area. Why is this? Because of our guts, you know, and what we eat. And some kinds of foods are very protective for our nervous systems, and some kinds of foods are very bad for our guts. And when you put a lot of fat or carbohydrates into our intestines, you get a different kind of bacteria living there that really stimulate our immune systems. And it's really quite remarkable how big an effect this may have. And so the problem is what's bad for you is what we like to eat. And that is a lot of excess carbohydrates, which is sugar and starch, and saturated fats. That's what the bad bacteria like to eat. And so we're not sure how much it changes things. We do know that studies have been done with vegetarian diets, and they don't do much for MS. But those people had pretty difficult MS. So it may be that they do something early in MS, or they just don't do enough to make it easily measurable over the space of a couple years. Intermittent fasting, similar issue. It's a metabolic. It changes your metabolism. It could potentially be really good for MS. It's probably good for your body. What do we know? Well, the studies for MS actually just show a few things. Coffee, very good. Okay. Believe it or not, a little alcohol, good. A little bit. Fish from the ocean, tuna, salmon, herring, cod, very good for MS. All right. Omega-3, probably why the fish works. Very, very good for your brain. Okay. These things we know, they're facts. They've been reproduced multiple times in research. And the Belgians like the beer part particularly. But they actually did research on this. But the British have done it too. And, the Brits like their beer. But as long as it's not actually more beer than is good for you is probably still good for your MS. But the good thing is about food is there's a lot of latitude, but there's a lot of room for health. And the benefits of eating healthy are big. The only other thing that's really clear, it's not really food, but it's seasoning, is salt. Lots of salt looks really bad. Now, we're not talking about normal recommended amounts of salt. We're talking about very salty food, and it probably turns the immune system on. Why does it do this? Why do these bacteria do this? It probably has to do with how we evolved to live, and I have my theories. My theory is, my long-winded theory for Stuart here, is your immune system knows it's time to go to work when you're well-fed, okay? And we're well-fed.
What can you tell us about black holes as seen in MS patients' MRIs, and do they actually show a worsening?
Okay, that's a good question. Why do we call them black holes? The formal name is T1 hypointensity, and it's a lot easier to say black holes. Black holes are really bad brain. They're brain that has been worked over irreversibly from the MS when they're called chronic. Acute ones, they're actually those swollen areas. They look black too, but we can all tell that they're swollen and they're not old. Old black holes are what we used to call bad MS, chronic MS plaques. And they are the more severe ones. The inflammation was either really severe or it came and went multiple times and just worked over that area of the brain to where there isn't so much brain there anymore. There's still brain, but it's mostly scar. And that's just as bad as it sounds. And why do you get those? Because you had very bad inflammation or very uncontrolled inflammation for a long period of time. And we measure those. And unlike the other MS lesions, they actually correlate very well with how bad the MS is and how disabled people are. So black holes, bad. Preventing black holes, good. And that's how you treat MS.
Thank you. That was a nice answer, length. Okay. Next, going back to EBV, Epstein-Barr virus, when it reactivates, is it also causing an MS relapse, or is it just in general similar to an MS relapse?
This is very good. Good question. We know this. We knew this 25 years ago. When it reactivates, you don't know it. You can't tell it. You can't feel it. It doesn't cause a relapse. It's not associated with brain activity on MRI. It's not associated with clinical activity. It happens regularly in people with MS. All right. They don't control it as well as other people. As far as when Epstein-Barr virus really gets out of control, you get hepatitis. If we sit on your immune system bad enough for long enough, your Epstein-Barr virus will get out of control and eat your liver. That doesn't happen very much in practice because we really don't knock the immune system down enough to do that in MS, but it does happen once in a while.
Okay, thank you. Next, you mentioned 4-aminopyridine and also amantadine for helping with walking. Can you explain the difference, and do you need a prescription? And could you tell people what your 4-aminopyridine is so you can remind them what this is about?
Yeah, 4-aminopyridine you can buy in the hardware store, and it's bird poison. We call it dalfampridine when it's medicinal. We used to call it 4-aminopyridine. The pharmacists used to make it. They still make it in off-label amounts, but it's in an extended release form. And if you were to say what it did, it makes cells more excitable. It makes muscle more excitable. It makes brain more excitable. It makes nerve fibers more excitable. And so when there's damage, it makes the signal go through with less energy, which is what makes it work better. And people walk faster, they're stronger, they have less tremor, they think more clearly, their muscles are stronger, their balance is better. None of that's allowed to be said by the companies that sell it. They walk faster. That's all they can tell you. So get out your stopwatch. It does work. And so, however, it also, if you're prone to epileptic seizures, it causes epileptic seizures. It will cause epileptic seizures. You cannot give it to people who've had epileptic seizures. They will have another very reliably. So not everybody can take it. It doesn't work for everybody. Amantadine is more like a signal that takes the brakes off. It was actually invented for the flu. It doesn't work for the flu anymore because it's resistant to it. It was then used for Parkinson's disease, and those Parkinson's people with MS said, geez, this makes my MS better. But what it is, it's more like an anesthetic drug than it's like like an amphetamine. It takes the brakes off many pathways in the brain, modulates them to make them work better.
Person wants to know if MS, if caused by a grandparent, could affect the child, the child of the grandparent, or would it affect the grandchild first?
So this is a good question because it gets to how genetic is MS. And MS is not genetic. The risk of MS is genetic. There are dozens and hundreds of genes that are involved in people's risk for MS. Why is that? Because you are here. Those genes help your ancestors survive. They are good genes. Most of them came out of Northern Europe. That doesn't mean they're evil. It's what Northern Europeans needed to survive the infectious disease challenges they had through the centuries, probably in part tuberculosis and the plague. And there's data for both of these, maybe even parasites. Because if you made it to 30 years old and had 2 kids, you were ahead of the rest of the people. And so those genes went forward and you got them. And you got them now in an era where people have sanitation and antibiotics and live to be 80, 90 years old. But the immune system is more likely to make a mistake when you have those genes. And it's more likely to go harder than the next person's. And many of these genes have to do with regulating vitamin D levels. And for some obscure reason that's part of this equation, they lower vitamin D levels, which makes the immune system more aggressive. And why that was invented in the cold, dark north, the way to survive, you'll have to ask the gods of evolution, because that's what happened. And this is what most of the risk for MS is genes that drive your vitamin D level. And the others all cause your T cells, which are the instigators of the inflammation, to go very hard. And basically when you make a mistake, it's a bad one. It's what your immune system is for. But that's what helped people survive. They are good genes. They have been good genes. They are very popular genes, but they are risk factors. They are not the cause of the disease. The cause of the disease is bad luck.
Okay, thank you. Next one, can inflammation in the brain be measured by doing a blood test for inflammation?
Sometimes yes, usually no. There is a blood test called neurofilament light chain that will probably be approved for MS that detects damaged brain leaking out into the blood. It is not very sensitive for milder degrees of inflammation. It is good for really raging inflammation. However, we can see raging inflammation on MRI scans. This test will probably get approved. It will not be a substitute for MRI scans. It may reduce the number of MRI scans that need to be done in people with very active disease who had positive tests to begin with. If your test has never been positive, it's not likely to become positive because you don't have that much inflammation at the time. Excuse me.
Thank you. Next. Let's see. It says, are strokes common in MS?
Strokes are common. Migraines are common. Arthritis is common. People with MS get the same thing everybody else get. So the older you are, the more likely you are to have a stroke. The more vascular risk factors you have, the more likely you are to have a stroke. 30% of everybody on the planet will have a stroke at some point in their life, and they're usually over 60. So it gets really dicey when you get older, and a stroke will destroy more neurological function in an hour than MS will destroy in many decades. They're much more damaging kinds of problems. Although strokes can be small, they often are catastrophic.
With spasticity, are MS people more prone to foot damage than the normal person?
Well, there is not as much damage to feet as there is to joints and tendons. And the biggest problem when somebody has a spastic foot is the muscles are very powerful that push your foot down and turn it in. And they're relatively weak that lift it up and turn it out. So what happens is people tend to step onto the side of their foot, and when you do that, you will sprain your ankle, and you can destroy your ankle with one good swoop of stepping really hard, and that is very bad ligamentous injury. It'll put somebody off their feet. This is why we use ankle braces and when people have weak feet and a foot drop from a weak foot. Other than dragging your toes, spasticity doesn't have a lot of problems with the foot. It wears out your shoe, the front of your shoe, but it will put you on your face, if you trip. That's the biggest danger to it.
All right. Does Flexerol fit on the spasticity scale, and what are the pluses and minuses?
So there are several medicines that are approved as antispasmodic medicines. Flexerol is called cyclobenzaprine. It's actually a medicine that's related to antidepressants, and it is got all the side effects of an older antidepressant and none of the antidepressant benefits. But it does relax muscles a bit. It probably has a mild pain relieving effect as well. But this is compared to the other drugs that are approved for treating spasticity. It is a very lightweight drug. It is a fairly safe drug as long as people use recommended doses. But it has, those medicine head, those side effects on your sweating and the dry mouth and things are pretty bad with that drug. There are some other drugs that are older, antispasmodics. Each one of them either has limitations, but the baclofen and tizanidine are the safest and the most effective of these drugs. That's why they're used. And if people have trouble with them, it's always worth trying to figure out how to solve that problem. Usually can be solved with dividing doses and pills.
Thank you. Next, are studies being done in the connection between immunological diseases and neurologic diseases?
Well, that's what the field I've been talking about tonight is mostly about. But immune disease, there are things that we think are immune diseases, but we can't prove they are. ALS is one of these. Alzheimer's disease is one of these. We know that there are immune components in these diseases. In fact, it's pretty large in Alzheimer's, and we're starting into treating Alzheimer's now in the way that we were treating MS 30 years ago, with ways that aren't so successful, but hopefully alter it in the long term. There are immune diseases that may affect other diseases. Some of the psychiatric diseases, like depression and schizophrenia, are thought to be immune diseases in part. We don't understand that very well. They don't happen enough. We can't treat them. The brain is a black box. We can't see what's going on in there. If you can't see it in a big enough, it's on MRI. If it's microscopic, and a lot of things, even in MS, are microscopic, you can't study them in a living, breathing person easily. But we know that there are ways to get at some of these things. But one of the biggest revelations was people with serious depression actually have inflammation in their brain. And the inflammatory cells are all turned on. And, it doesn't surprise us who work with MS, because we know that those people who have MS have a lot of inflammation. They have a lot of mood problems too. But we don't know how much is immune disease. And as people get older, the immune system tends to get stuck on. We know that's what causes arthritis. We know that's what causes a lot of lung disease. We know that's what causes a lot of cancer in the bowel and in the lungs, is that the immune system's just activated for long enough to drive the cells to act abnormally. And we don't know how to deal with all those things. But actually, there's a lot of research that goes on in this field. There's life extension research has got a lot of interest in these areas. How do they do that? Some of these drugs are anti-inflammatory drugs. They're even immunosuppressive drugs, seem to prolong function, because what does it do? Well, it triggers the things to help the cells clean up their act and stop causing the inflammation. We don't do any of those things for MS right now. There's no data that they work, but can't say what will happen in the future.
Thank you. Last question. What does Ampera do for people with heat sensitivity in addition to gait issues?
Well, heat sensitivity was always thought to be one of the reasons we would use those medicines. But in practice, it doesn't seem to be a reliable indicator of somebody who responds. People may respond who aren't heat sensitive, and people may respond who are heat sensitive. So it's unpredictable, and so we don't use that. But sometimes it's very helpful in those folks. Cooling, on the other hand, for people with heat sensitivity is a particularly valuable strategy, because they can feel that. And there are phase change cooling vests that are out there that are very popular, but the air conditioner running lower is also probably the most common way people deal with that.
Thank you.
Thank you.
Our last question. Did you all enjoy? Great. Thanks a lot, and everybody have a great night. Drive carefully.